Thank you very much, Dr. Han. And hello, everybody. And I'm Lee from Korea. And welcome. Thank you for your visit to our symposium. Before my presentation, Dr. Han explained that the research of immediate loading with the energy implant for 2 years was very predictable. As you already know about whether you can get a reliable and a strong initial stability or not is very important for success of implant treatment. So how can you get a reliable initial stability? The conventional surgical protocol for implant placement is shown in this figure. And because the bone density gets weaker and weaker when it goes from type 1 to type 4, it is difficult to get the stronger initial stability. So we should wait for sufficient osseointegrations from 3 months to 7 months according to the bone density. However, if it's possible to higher initial stability regardless of bone density, we expect to start almost at the same time and reduce the healing period. Then we are able to provide comfort and dependability to the patient. That's what we want to do. Last year, in the Jeju Symposium, we suggested immediate loading when ICQ barrier is over 70 and insertion torque over 40 NCM. Consequently, we can realize the one-day implant concept. If these are satisfactory, can we anticipate the possibility of the immediate loading? Let's take a look at this case. This is a preoperative panoramic view and clinical photo. And here you can see the untreated first molar with wide hid edentulous ridge at the lower left side. So I made a plan to place the implant using R2 stent for second molar and a crown for first molar. This is post-operative panoramic view and periapical radiographs. And right after surgery, we got ICQ barrier 86 on buccal side and 88 on lingual side respectively, which were meant to be excellent initial stability. As a result, we could finish this case with immediate loading. This is showing the condition of occlusion with a temporary crown. 3 weeks later, the patient told me that he had felt a little bit slight inconvenience. So I checked the ICQ barrier again, and it was dropped below 60. Therefore, I stopped the loading immediately. After waiting for healing and sufficient osseointegrations during 2 months, ICQ barrier again increased to 75 on buccal side and 78 on lingual side respectively. So we corrected the abutment again and delivered the final restoration. 6 months later, the follow radiographs on the right side show the stability of the implant. Why? Of course, implant will succeed. But why we did fail to do immediate loading in spite of the strong initial stability, which the ICQ barrier is over 80? Let's take a look at another case. What do you think of this case? In this case, it seems that the minimally invasive surgery and the immediate loading are also possible because of sufficient bone height and width for implant. Do you agree with me? Yeah, so we tried to do an immediate loading right after surgery. Although all of the conditions was good, but we failed to do so because of the lower initial stability, which was ICQ barrier less than 70. As Dr. Chang-Woon said before, the ICQ barrier was less than 70, which was not enough for immediate loading. 4 months later, we measured the ICQ barrier again. The ICQ barrier were increased from 60 to 72 on buccal side and from 65 to 76 on palatal side respectively. Then we started the loading by zirconia customized abutment and provisional restoration and checked all of the conditions during 2 weeks. As you have seen, implant was succeed, but immediate loading was failed. Why? Why we didn't obtain the proper ICQ barriers for immediate loading? Finally, how about this case? It also seems that the bony condition is good for implant treatment with immediate loading, isn't it? Of course, there is a resorption on buccal side, but enriched implants are very useful in this case. We did implant placement using R2 stent and got the proper initial stability for initial stability and ISQ value for immediate loading, which was 78 on both sides. So we delivered the temporary crown and started loading. After 6 weeks, there was no change in ISQ value. And then we made a final restoration, and 7 months later, the follow radiographs on the right side showed the stability of the implant. Which is difference among these 3 cases? Why would the immediate loading be possible in some cases, but in others? Why? Dr. Han already told you that we could try immediate loading when the insertion torque is over 40 NCM and the ISQ value over 70. Actually, judging the possibility of immediate loading, insertion torque is more important factor than ISQ value. Of course, the ISQ value is also important, but the ISQ value doesn't mean the 100% osseointegration. So, in addition, here are a couple of things we should consider. Bone density and occlusion. That's it. Bone density contains cortical bone thickness and trabecular bone density. The intensity of initial stability will vary according to these factors and during protocol as well. And controllable occlusion is also important. If the patient had poor functions such as bruxism and clenchings, we need to control the occlusion force carefully. Only if 4 criteria are satisfied, we would then recommend to do immediate loading. So, how can you judge the bone density? In 1988, Dr. Carmish reported the 4 categories of bone density depending on the cortical bone thickness and trabecular bone pattern. But there was no quantifiable standard. Most of the cases, we guess the bone density based on the radiographs and clinicians' feeling during drilling, right? So, Dr. Carmish suggested the CT view is more effective to evaluate the bone density precisely. However, the CT image is shown on the screen black and white based on the relative density of tissue. So, CT image may be confusing to collect bone density analysis because of the limited color expression. In other words, we may be able to evaluate the cortical bone thickness to an extent, but it is difficult to discriminate the cancerous bone density. So, we attempted to change from black and white image to color image based on the relative density using R2Gauge software. Which is better to estimate the bone density more easily? The color image is much better to analyze cancellous bone density and the cortical bone conditions, more intuitive. On the right side, the yellow color means the cortical bone. In other words, by using the yellow color, the relative bone density of the rest of the structures can be assumed. In addition, by placing the implant before surgery, it is possible to anticipate how much implant the surface is engaged to the cortical bone. By the extent of engagement between implants and the dense bone, we know how strong initial stability is capable and how to modify the drilling sequence. Many studies have reported that the immediate loaded implant must engage dense cortical bone aspect to ensure the extra stability. So, judging from engagement between implant and dense cortical bone, it was perfectly possible for us to get strong initial stability and succeed in immediate loading. Let me give you some cases. Can you imagine what the bone quality is, D3, D4, or D5? Let's change this to color image using R2Gate software. What about this? The color image would make it look much better for comparison among the relative density. The color of a cancellous bond looks like softish. And we can expect that the bond density is very loose and difficult to do the immediate loading. Even if the immediate loading is impossible after surgery, by controlling the drilling sequence carefully, we get the proper inch stability for success of implant treatment. In such cases, we think you should do 2 or 3 more steps downside drilling, or place the wider and longer fixture within the limit of the bony condition. This is another case. This is Dr. Han's case, and which the lower left second molar was extracted and implant was placed immediately, and followed several considerable factors we said earlier. Through CT image, we could find out the patient had a thick cortical bone. By imaging the ideal implant position and the proper size of diameter, it seems the implant could be almost engaged into the cortical bone. After exchange to color, we can be confident of bone density. So we made a plan to place 5.0 by 10 millimeter NUH implant to the surgical site, and drilling was performed according to the diagnostic drilling protocol, and the implant was placed. And then we can evaluate the outcomes by checking the insertion torque and the ISQ value. The ISQ value and the insertion torque was very high. And that means we are ready for immediate loading. It's different, but it is same to use lens drill and the 2.0 twisted drill. Of course, typical considerations and cautions are also same. Bone density of D4 and D5 are so loose, then you should control the drilling protocol carefully. Especially in D5, we think you should use only 2.0 twisted drill for implant placement. As Dr. Mika said before, due to the specific design of NUH implant, 2.0 twisted drill is enough to place the implant in D5 bone density, which is very loose, such as soft tissues. In D4, 2.9 millimeter twisted drill is final drill, and then we can get the stronger inch stability. In D3 bone density, we recommend drilling 2.9 or 3.3 twisted drilling to full depth, respectively. If needed, 3.8 twisted drilling to half depth. And last, D1 and D2. As bone density is getting harder and harder, we recommend drilling twisted drill, which has near same diameter of fixture we want to use. Another option, we think you should exchange the fixture diameters for the smaller size, 4.0 by 10. Okay, to improve the predictability of immediate loading, which means one-day implant concepts, and understanding 4 diagnostic keys should be considered. These 4 diagnostic keys will enable to clinicians to decide the treatment options and clinical procedures that are more specific to the desired outcome, therapeutic outcomes, such as the minimally invasive surgery and the immediate loading. If conditions satisfy the 4 qualifications on the left side, we recommend to follow the one-day implant concept. If not, we think should measure the ISQ value 3 times, right after surgery, 3 or 4 weeks later, and last 6 weeks later. After that, you can decide to progress the prosthetic procedure or not. NUH implant system has a little bit different characteristics compared with another implant system. It may be possible to make a big difference. So I hope all of you try to do your challenge with us. Thank you. Thank you very much.